It's 8:02. So, hi everyone. My name is Isabelle Lefebvre-Vary. I am the co-founder and executive director of Fertility Friends Foundation. We are a charitable organization that offers grants and educational resources to individuals and couples who are going through fertility treatments and can't afford them. As you all know, it's a very expensive journey to be on, and we're trying to alleviate the financial burden of it and create a more equal access to fertility care. Tonight is part of our Your Fertility Guide webinar series that we launched a year ago, and Dr. Shaw was one of the first speaker of the series back, I think it was March 2025. And we are very, very happy to welcome her again. The series is presented by EMD Serono, the proud sponsor of Your Fertility Guide, and we're very happy that they decided to come on board so we can expand our content thanks to their generosity. Back to Dr. Shaw. Welcome. Thank you so much again for joining us tonight. Dr. Shaw is a fertility doctor at Olive Fertility Center in BC, British Columbia. She is working every day with patients. The first webinar that she did was about endometriosis, and tonight she's going to talk about PMOS, which was formerly known as a PCOS, and I'm sure that Dr. Shaw is going to address that. Good evening, and thank you so much, Dr. Shaw, for joining us. It's an honor to have you back on our series.
Thank you, Isabel, for the lovely introduction. It's an honor for me to be back to hopefully shed some knowledge and get more insight and help people gain more insight into a really important fertility condition and hopefully just answer some questions. And I have quite a few slides to go through. So my hope is that we can potentially go through most of the slides. You can feel free to put your questions in the chat box, but hopefully the subsequent slides might answer some of the questions you might have. So without further ado, I'll just get started. So today I have the pleasure of talking about polyendocrine metabolic ovarian syndrome. It is a condition that affects many individuals. We're going to talk about what the condition is, how it is diagnosed, the connection between PMOS and fertility, treatment and lifestyle approaches, options for individuals trying to conceive, and then sprinkled throughout the presentation, I did add some common myths and questions that may be associated with that particular section. So hopefully that will keep things a little bit more engaging as well. So the first question is, of course, what is PMOS? It was previously known as polycystic ovary syndrome, PCOS. So you'll see that acronym quite a lot in the literature and in the previous studies and research on this topic, just to know that it is interchangeable because of the recent name change. We will be referring it to PMOS. It is the most common endocrine condition affecting reproductive age women. It is a syndrome, which means it's multiple interacting endocrine disturbances. It affects worldwide 170 million women in their reproductive years. It has been previously mainly known as a gynecologic condition. We know that there's reproductive impact like irregular cycles, infertility, pregnancy complications, endometrial hyperplasia, or cancer risk. But more and more, it's known for additional impacts like metabolic associations, psychological associations, as well as dermatological considerations as well. It is underpinned by an endocrine disturbance in insulin, androgens, neural endocrine signaling, as well as ovarian hormones. And that is why it has such a wide-ranging impact. We see that BMI is generally higher in people with PMOS than those without the conditions, and it can contribute to the overall severity. And overall, it is important to note that PMOS has multi-system health impacts. So we're mainly talking about things in the context of fertility. However, it's really important to remember the other important medical considerations as well. And as Isabel had mentioned a little while ago, um, in the beginning of the conversation, this new renaming was actually just this year, just several months ago. It is a lifelong multisystem disorder rather than a localized ovarian pathology, which is why this name change went from PCOS, polycystic ovary syndrome, to polyendocrine metabolic ovarian syndrome. Both really long names, honestly, but I think it's more in keeping with what the condition really is, and it underscores the central role of metabolic dysfunction in the actual presentation. Why PCOS was called PCOS in the beginning is actually interesting. It was previously more of a surgical diagnosis. It's been a condition that has been recognized in medical literature for quite some time. And in 1930s, it was named PCOS based on more of a surgical finding because of multiple small fluid-filled sacs or cysts is what they named it to be on the ovaries. But further after that, decades of research have now confirmed that the condition extends far beyond the ovaries, and that if we're just talking about polycystic ovaries, it is a scientific inaccuracy because it's mentioning that these cysts are pathological, but that's actually not the case. These cysts are actually just early follicles that are not developing or as or are being um, matured appropriately rather than truly pathologic cysts. So, anyways, this is why the name was what it was, and now this is one of the big reasons that we're renaming it to really underscoring the true central role of metabolic deficiency as a part of PMOS. Um, so, talking about numbers, um, it's really important to recognize that this condition has a big impact. It affects 8% of reproductive age women. Um, 90% of women who have irregular periods can have been shown to have or have been associated with PCOS or PMOS. And then about 30% of women who were found to not have periods this has been attributed to PMOS. And then, of course, it's associated with a large proportion of patients with excessive hair growth, acne, and then a large proportion of patients would have type 2 diabetes, high blood pressure, and sleep apnea. It is a very common condition, especially amongst the patients that I see every day in my office. And the challenging thing with PMOS is also that the cause is actually multifactorial, hence why the PCOS terminology doesn't really fit with what it is, which is a metabolic syndrome. It's a it is attributed to high LH production in the pituitary gland, high male hormones being produced within the ovaries, insulin resistance and high insulin level, and this all leads to a bit of a feedback loop that makes the rest of the metabolic and fertility impact possible. In terms of diagnosis, there are several diagnostic criteria that have been published or widely used, but I would say that the most relevant and widely used criteria is the Eschri-Rotterdam criteria that was first recognized in 2004. But all of the different societies and their guidelines do tend to highlight that there is evidence of higher androgen, which is another word for male hormones, in excess compared to what we typically see in the female person. However, based on the Rotterdam criteria, patients only need to have 2 out of the 3 diagnostic presentation. So it could be either clinical or biochemical signs of hyperandrogenism. Um, in terms of their menstrual pattern, they can have oligo or anovulation, which means irregular or a lack of ovulation or a lack of menstrual period, as well as the observation of polycystic ovaries. And we'll break those different criteria down in the subsequent slides. It's also important to know that PCOS can be quite variable in its presentation, which is why it is relatively controversial in terms of how these different societies have found ways of diagnosing this condition. So it is important to know that one patient with PCOS may not present exactly the same as other patients in PCOS, but doesn't necessarily mean that their condition isn't as severe. It just could be different types of conditions or underlying cause that hasn't been fully elicited. It's also important that we need to exclude other disorders because there are other medical conditions that will look or present similar to PMOS. And of course, if those disorders are the true cause of PMOS or the true cause rather than PMOS, then the treatment could be very different than the general treatment that we would recommend for PMOS management. Some of these conditions can be a little bit more scary sounding. So things like Cushing syndrome, androgen secreting tumors, hyperprolactinemia or kind of pituitary adenomas or thyroid disorder. Some of these conditions can be congenital, leading to the similar presentation as PMOS. And then other medications can also create presentations that may mimic PMOS. So it's really important that if you suspect that you have PMOS, that you obtain medical evaluation just to ensure that there is nothing else that could be at play, because some of these conditions can be life altering and serious. So it's important to rule out these conditions. And what we do is we would, as physicians, we would order, of course, talk and understand the history, do a physical examination and laboratory testing, and maybe even imaging studies in order to rule out some of these more concerning mimickers. So one of the first conditions or criteria within the Rotterdam criteria that I think it's important to talk about is the signs of hyperandrogenism, so high male hormone levels. And it doesn't necessarily have to be high in terms of blood work to meet the diagnosis. One can also be meeting the diagnostic criteria if you have clinical presentation of hyperandrogenism, and that would be considered as those would be symptoms of like abnormal hair pattern, male like hair pattern, and these are some of the places that patients might notice that they have like more hair or more darker, coarse hair than others. And I think it's important to know that the hair pattern may be different based on people's ethnicity, dependent on whether or not someone has used laser hair treatment or mechanical hair treatment. So sometimes if we're not quite sure if patients have, a clinical pattern that is of concern, we may then add additional blood work in order to further understand if there's a high male testosterone or male hormone levels. So you don't necessarily need blood work. Sometimes blood work could be ordered if the physical symptoms aren't necessarily answering the question of hyperandrogenism enough. Of course, there's also hair loss, which is male pattern that can be associated with PMOS, as well as signs of kind of acne or like much like a higher amount of oilier skin can sometimes be a sign of hyperandrogenism as well. But of course, people do present a variety of different physical symptoms. So it is important to have a physical examination and speak with your doctor about your symptoms to better understand if this is considered normal or part of an abnormal pattern. And one of the important thing I did want to add in terms of the signs of hirsutism or male pattern hair growth is the onset and severity of it. So what is usually less concerning would be like a slow, insidious kind of or lifelong pattern of hairy hairier presentation. However, if someone presents with, more sudden and suddenly very severe, very quick onset of concern of some of these kind of male hormone abnormality in their presentation, I think that's actually something actually concerning and may be associated with like an androgen secreting tumor or something more concerning. Again, I think it's important if you ever notice any symptoms that come on really quickly in a very severe pattern, then that is really an urgent reason to obtain care and have real diagnostic workup in order to understand what could be contributing to the symptoms. Um, the second, and especially important for fertility, diagnostic criteria is a symptom of oligomenorrhea or irregular cycles, or amenorrhea or lack of cycle. There are different definitions depending on when someone started having where you are from the pubertal transition. So it the first year after menarche, the first menstrual cycle, it's actually fine if the cycles are really irregular. There's no clear pattern to it in the first year. That is okay. That's just part of the pubertal transition. But within the first year after the first year from menarche, between year 1 and year 3 after menarche, we should expect that the cycles are ideally more than 21 days and less than 45 days. And if it's beyond those ranges, then it could be considered as irregular cycles. And if someone has been 3 years after menarche, the beginning of their menstrual cycles, we should expect that cycles are tighter, every 21 days to every 35 days, or at least less than 8 cycles per year. Oh, sorry, or more than 8 cycles per year. So anything beyond those ranges are considered irregular cycles. And if someone has periods that are over 90 days for any one cycle, 1 year after menarche, then that would be also a concern for irregular cycles, or could be defined as irregular cycles. So some patients come in and they are interested in more kind of fertility evaluation, and they may have a history of irregular cycles, but then they've been on birth control pill for a long period of time. And of course, birth control pill generally leads to regular cycles because of the cyclic use of birth control pill. So one common question I get clinically is patients would ask, how do I know if I have PMOS if I'm using the birth control pill? And the truth is, sometimes we don't know, because if someone's history is really strong, say before the birth control pill, their cycles are, a specific length and they really remember it and they have records of it, and they have some of the other symptoms that have been or signs that have been diagnosed in the past, then of course we can make the diagnosis of PMOS. But birth control pills can mask some of the symptoms or presentation of PMOS. If someone really truly wants to have the diagnostic clarity, or it's is medically beneficial to have the medical clarity, we can consider withdrawing or stopping the birth control pill for 3 months, with obviously a very strong and reliable backup form of contraception during that time, in order to elicit that information a little bit more. However, I think this is an important thing to talk to your doctor about, to weigh the pros and cons of, is it worth doing this diagnostic evaluation, or would it simply just be better to continue the birth control pill, because it can be an effective treatment for some of the presentation of PMOS. And then the last criteria is polycystic ovarian appearance of the ovaries on ultrasound. Generally, the diagnostic criteria historically have been based on ultrasound, as either the presence of 20 or more follicles, or an increased ovarian volume with lower tech ultrasound devices, or in patients with poorer visualization. However, there is a newer criteria or a newer diagnostic test that can be used to diagnose polycystic ovarian appearance, and it's this hormone level called AMH, anti-Mullerian hormone. The one caveat is that the AMH, there's not a great standardized limit for AMH for diagnosis of PMOS. So I would still say clinically, we use a lot more ultrasound to make the diagnosis of PMOS, but there are patients in certain areas where ultrasounds are just difficult to access, right? And AMH can be an alternative for making the diagnosis for PMOS. One of the common questions that I get from my patients would be, if I have irregular menstrual cycles and I have signs or biochemical evidence of hyperandrogenism, do I still need an ultrasound or AMH to make the diagnosis? And the truth is no, because based on the Rotterdam criteria, um, the correct diagnostic criteria have been met 2 out of the 3. So an ovarian ultrasound and AMH is not necessary. And if it's difficult to access and difficult to do, it may not really add very much. Another question is, can my ethnicity affect ultrasound findings? And the truth is, there are some ethnic differences between what we expect to see, and we do see a higher incidence of PCOM, polycystic ovarian morphology, those ultrasound findings in patients of Southeast Asian and Eastern Mediterranean descent. And it's important to know that there could be some confounders with ethnicity. So we've reviewed some of the diagnostic criteria, and now I think it's important to talk a little bit more about the health risk. And it's important to know that if someone is diagnosed with PCOS, patients would benefit from following up with their family doctor to monitor or screen for type 2 diabetes, screening for high blood pressure, high cholesterol. Sleep apnea is a really important condition that that PMOS is linked to, and it can be associated with worsening hypertension, daytime sleepiness, and kind of long-term metabolic risk factors, in addition to having just PMOS alone. So I think that's an important thing to screen for as well, or at least be cognizant of talking to your family doctor about. What I truly worry about for my patients is the risk of endometrial hyperplasia or dysplasia or cancer. And we know that when patients are not shedding their lining regularly, if you have a very low number of periods per year, it potentially can have a higher risk of endometrial hyperplasia. So it is really important that if someone has those presentations, even long after we've completed fertility treatment, that they should seek care. Or if fertility is not a major concern for that individual person, then we could talk about different ways for menstrual suppression or endometrial protection in order to help reduce the risk of these conditions occurring while the periods are irregular. And association with mood disorder has also been reported as well. The prevalence of depression and anxiety is up to 76 to 80% in patients with PMOS or PCOS in studies. And there's certainly a higher risk of depression and anxiety in patients with this condition compared to those without. So there are some additional linkage to mood disorders as well that's important to be aware of. Um, Diagnosis of PMOS is considered a lifelong diagnosis. So, with aging, there are still some changes that can happen across all 3 of those diagnostic criteria. And of course, it's not the same for every single individual, but we do see that menstrual cycles can change back to regular over time. So it may be um, you may fall out of the diagnostic criteria, but once that diagnosis initially is made, the studies would suggest that overall some of those metabolic and health indicators or health risk would still be relevant to know about throughout time. We also see that ovarian volume and follicle numbers can decrease, but that's normal with aging. That is expected, and like other women without PCOS or PMOS, this is expected to be seen. There's also some inconsistent evidence on whether or not postmenopausal women with PMOS could have higher androgen levels compared to the non-PMOS controls. Um, Women with a PMOS with aging can report more hirsutism, especially when they're postmenopausal. And there's been some studies to show that the timing of menopause may be up to 2 years delayed from the average person without. So it's important to know that this is a lifelong condition and has far-ranging impact on someone's life rather than just fertility. However, as a fertility doctor, um, what I typically see is patients coming to me when they are in their reproductive years, and often their presentation to me is to try to conceive. And these are the range of options that we would talk to patients about in terms of things to consider in terms of treatments. One of the most important first line treatment is diet and exercise lifestyle. It's always a a baseline intervention that I like all my patients to partake in order to make the rest of the treatments more effective. Lifestyle changes, if we can offer them to maintain a weight as close to ideal as possible, can improve pregnancy rates, decrease miscarriage rate, and improve the success of fertility treatments when and if they're necessary. We know that insulin resistance can affect 70% of patients, 70 to 90% of patients with PMOS, and is further exacerbated by excessive weight. So it is really helpful for patients to consider dietary changes. A Mediterranean diet is what we typically recommend. Um, there's perhaps some kind of interest and some evidence towards keto or low carb diet in order to help with weight management or weight loss. Of course, um, when I talk to patients about weight, I do like to preface by saying that weight is a very sensitive topic to discuss. And I don't want the focus to be on weight. However, patients should know that sometimes weight loss of even as little as 5% can have metabolic, reproductive, and psychologic benefits. But I don't want people to be looking at the scale. I want patients to be having a lifestyle, manageable lifestyle that can have long-term benefits. With regards to exercise and activity, it is um, a regimen and kind of I recommend kind of a slow start to a more regular exercise routine if possible. And sometimes it is not just as easy as changing your diet and exercise. Sometimes lifestyle intervention can include behavioral interventions like goal setting, self-monitoring, assertiveness training, reinforcing changes, relapse prevention. All of these may be needed in tandem to effect the change that we want for the lifestyle, diet, and exercise benefits. So I think it's really important to look at everything in context. Some of the questions that I would usually get after I talk about lifestyle and interventions would be, is there a best type of diet or exercise? And the truth is no, right? And I think sort of refer to it a little bit in my presentation, is that ultimately I don't want people to focus on a number, on a scale. I don't want people to focus on a specific size. I want people to focus on healthy eating. It's really important to think about your personal preference, what is sustainable for the long term, and ideally just something that's nutritionally balanced, right? We want people to be having um, uh, healthy meals, and if it's easier to just go with the Canada Food Guide, then just go with the Canada Food Guide. And if there are some specific cultural or personal preferences that you want to work into your regime, that's fine. I think it's just about making it a switch towards things that are lower carbs or lower glycemic index, more fiber, more satiating, and overall less saturated fat, more omegas, and more plant oils or olive oil as a diet or as an oil or fat source. Um, and I think it's important that that if this is doable on your own, great. And if it's not, sometimes professional help with a dietitian may be helpful. So again, just know that there's not one specific diet that's recommended. Do what works for you. And the same goes for exercise. Any exercise is great, but aim to have a minimum of 150 minutes of moderate intensity activity per week with muscle strengthening activities for resistance and flexibility on 2 non-consecutive days of the week. That's the overall recommendation for weight and health management. And for weight loss, may have to go up to 300 minutes of moderate intensity activity. But again, start low, start slow, do what's manageable. Sometimes doing it with a partner or a friend or a group may be helpful. And sometimes it may need a personal trainer, or some sort of more regimented regime. And that's okay. I think it's all individualized to see what works best individually. So don't forget to consider allied health professional, your family doctor, and potentially other resources that are at your disposal, like friends and partners. Another question I get for patients considering, the first line management of lifestyle intervention would be, what about Ozempic, right? What about kind of a more medicalized way of leading to weight loss? Um, and GLP-1 agonists can be considered for weight management for certain patients. However, the safety data in pregnancy for the use of this medication is lacking. So, effective contraception is recommended. So, for patients who are actively trying to conceive or require a shorter timeline to conception, then a GLP-1 agonist likely is not the best option. However, again, we have to talk about the patient's talk about the medication side effect, the patient's fertility plans, timeline. There is also currently a significant cost to this type of treatment as well as to understand if there's any other medical conditions that could be impacted by this medication. So I think it's important to take all of it in context to consider the use of GLP-1 for weight management. Most patients, I would say, obtain this medication with their family doctor, but of course, you can always run things by your fertility doctor or someone who's looking after you for your PMOS to see if it makes sense in your specific situation. Um, Another related question would be bariatric surgery, and it can be considered for weight management as well. However, similar to GLP-1 agonists, is that effective contraception is strongly recommended until the weight is stable and at least 1 year after surgery. Otherwise, there is significant pregnancy and neonatal risk if conception occurs before that time. So, of course, the first line treatment would be the lifestyle intervention, but sometimes people have already done those lifestyle treatment, but by the time they come to see me, or they've done it now for some time, and they come back and it's just not delivering the results that they want. There's still irregular cycles. It's still hard to time things to try to conceive. And there's still the frustration that comes with the oligomenorrhea. So what do we do after that? What I generally recommend is considering some sort of medication for ovulation induction. And letrozole is the first line treatment and has been associated with a higher live birth rate in previous studies compared to other types of ovulation induction agents. Um, the way that this treatment works is that you would take it in the follicular phase of your cycle. Femara is a brand name for letrozole, but yeah, anyways, it's not under that brand. It's not always under that brand name, of course, but you would take the medication from cycle day 3 to cycle day 7. Then you would monitor your cycles either with ovulation prediction kit, which is the urine pee stick to see your LH levels. And generally, the LH level spikes prior to ovulation. And that's how patients can detect ovulation and try to have timed intercourse at the appropriate time. For patients with irregular cycles, the use of ovulation prediction kit can sometimes not be so helpful because, as we had talked about in the very beginning of the presentation, PMOS is associated with higher endogenous LH levels to begin with. So someone might already have just higher LH levels that can cause a lot of false positives and irritation with using the ovulation prediction kits. And if that's you, that's not a problem. Just talk to your doctor, and they can talk to you about ways around it. So either that's having timed intercourse every 2 or 3 days, just or every day, probably every 2 or 3 days is probably most manageable. But this way, you're even if you're not tracking ovulation or not accurately tracking ovulation, you're still having attempts frequent enough that even if you ovulate without you knowing, you could still become pregnant during that time. Or sometimes people can do monitoring in a fertility clinic where we can offer ultrasound or blood work monitoring to help a more accurate prediction of when you may be ovulating to help you concentrate your effort to the most fertile day. However, depending on where you are, what your local resources are, there's some cost involved. It may or may not be something that someone is able to access, but it is a really good option to help patients monitor their cycles. Additionally, you can sometimes even do blood work to check in the luteal phase. So luteal phase is the phase of the menstrual cycle after someone has ovulated. So checking in the luteal phase does not improve your chance of pregnancy because you've already ovulated and the egg is no longer most likely no longer viable. So often the luteal phase progesterone check is just to make sure that you did ovulate or give you some reassurance so that you're not sitting there waiting for 2 weeks to see, hey, did I actually ovulate? You have a biochemical evidence that you've ovulated to give you some confidence. And if you did not, then at least you can come back earlier to seek help or with your doctor so that they can offer you a different treatment. So again, there are a variety of different ways of monitoring your cycles with letrozole. So one option may fit you better, but I would recommend talking to your doctor about how your cycles are, whether or not you track ovulation with ovulation prediction kit, and whether or not that's successful for you, and they can help you figure out what option works the best. Um, there is a adjuvant medication called metformin that some may consider using if they have PMOS. There's mixed data to show that it restores ovulation and can potentially enhance pregnancy rate because it can help provide management of insulin resistance for patients with PMOS. While it can help with ovulation, it hasn't been associated with a clear improvement in live birth rate. And obviously, that's the most important endpoint of what we want through fertility treatment. Um, However, it is more clearly beneficial for prevention of metabolic health complications like diabetes. It's generally not recommended to be used on its own because of the presence of other medications are more effective. So it can be used in combination rather than as it is alone. We have more evidence for its benefit for patients with higher weight index. So for certain patients, they may not benefit from using metformin, but others, there may be a bit of a better evidence for benefit. Again, you'd have to talk to your doctor to learn a little bit more about whether or not metformin should be considered for you. So that would be the general second line treatment. So lifestyle, um, weight maintenance or management, and then plus or minus letrozole for ovulation induction. Um, if you have progressed through that regimen and or you choose not to do some of the other options and choose to just have something that has slightly higher effectiveness, then some can consider gonadotropins. These are injection medication that mimics FSH and LH that your body naturally secretes to stimulate the follicles from the ovaries. It is generally a more effective way of leading to ovulation. However, it's second line because there's a lot of considerations with it. It's significantly more expensive than oral agents. It requires ultrasound monitoring. It requires daily injections. Not everyone can have access to these injections and ultrasound. While it gives a higher chance of pregnancy, it is also associated with higher risk of multiple pregnancies and even higher order multiples. We do know that multiple pregnancies, like twins or triplets and other higher order multiples, are not ideal compared to a singleton pregnancy. Higher risk of diabetes. On top of gestational diabetes, risk is already higher for patients with PMOS. Higher risk of high blood pressure, preterm birth. Babies that are born with prematurity have higher risk of major complications like eye problems, feeding problems, temperature regulation problems, brain problems, as well as for mom, higher risk of cesarean section and complications associated with C-section. So again, this is why gonadotropins are generally not considered one of the first things people try, but it can be considered if other treatments fail or if other options are really not recommended or applicable for that individual person. Um, this would be the schedule or the typical type of schedule for patients undergoing injection medications to help with ovulation. But you can see it's many injections over many days and ultrasound monitoring. And then often there's an extra medication to lead to an ovulation or follicular maturation, not always, but sometimes. And then often patients do add intrauterine insemination with it, but it can also be done without intrauterine insemination, which is a procedure where you would be at a fertility center, would take the partner's sperm, wash the sperm, remove debris, concentrate the sperm, and help deliver the sperm through the cervix into the uterus as close to the releasing egg as possible. Again, that's not always necessary, especially when someone just has irregular ovulation, but can be considered with patients with other fertility considerations. And then the later line options is in vitro fertilization, IVF. Um, in the absence of indications for IVF, we can consider offering this treatment for patients with PMOS and ovulatory infertility, and especially if they have not been successful with other therapies. Um, it is associated with more intervention, right? It is associated with um, about a 2 or 3 months treatment. First is to prime the ovaries to synchronize the follicles before the gonadotropin injections instead of doing low dose gonadotropin injections, similar to kind of the GnRH, the gonadotropin treatment that I talked to you about just now, you would be taking higher dose of injection medications so that instead of having 3 to 4 follicles growing, we could get 10 to 15 follicles to grow. And during that time, there will be daily injections, multiple ultrasounds until the follicles are in the mature range. That's when we'll organize an egg retrieval surgery where a ultrasound is guiding a vaginal needle through the vaginal wall into the ovaries to retrieve the eggs. Once the eggs come out, they are fertilized with sperm in the lab, either naturally, just putting sperm in the egg in a petri dish and letting them naturally fertilize, or helping with the sperm by a laboratory treatment called ICSI, intracytoplasmic sperm injection, where the laboratory staff or the embryologist will look through the sperm sample for the most motile, normal appearing sperm, and then insert into the egg to help the egg and the sperm meet. And then embryos are grown in the lab for about a week until they're ready to be transferred into the uterus. So that would be called a fresh transfer. So about 6 days after the egg retrieval would proceed with the embryo transfer. However, often patients with PMOS will require a frozen embryo transfer just because when there's such high number of follicles, high estrogen level at the time of the egg retrieval and after the egg retrieval, and when there are um, um, like a longer procedure that's done in the ovary to retrieve the many follicles that have been grown. Sometimes there are higher risk to doing a fresh embryo transfer. Therefore, for patients with PMOS, the recognized safest option would be to freeze the embryos once they get to a blastocyst or an advanced stage, about a week old, and then letting the body recover 2 weeks after the egg retrieval, you should expect a period. And then with that period, then we would start preparing the lining for an embryo transfer. So about a month from the egg retrieval generally would be the frozen embryo transfer. So it takes longer. It's costly procedure to undergo IVF. It does have a very high pregnancy rate, that probably one of the highest pregnancy rate, and gives option for embryo banking. So when someone undergoes IVF treatment and you can freeze multiple embryos, you can transfer as many embryos as you need to become pregnant, but potentially have excessive embryos that you can freeze for the future to complete a larger family size. But it's just higher risk overall with surgery, with a pain during the procedure, the risk of over response to injection medication. And of course, there's some lifestyle implications that one should be concerned or considering when they plan for IVF treatment, just because of the long duration of procedure and treatment. So this is a slide to show what the egg cell looks like after fertilizing with sperm for the first day. And then the embryo will keep growing and growing and growing into the blastocyst stage where it is frozen or transferred. One of the other option or relevant consideration for IVF is that for patients with certain indication, we can offer something called pre-implantation genetic testing. So for an embryo that makes it to day 5, 6, or 7, blastocyst stage, some cells from the part of the placenta, the part of the embryo that eventually will form the placenta, can be biopsied, and the genetic material within those cells can be analyzed to see if there are any missing or extra chromosomes within those cells, or some patients, if they have risk factors for specific single gene mutations, can also identify those issues within those embryos so that you can make a decision about whether or not you would consider transferring that embryo or not, or another IVF cycle if there are no additional embryos that could be transferred. And then in terms of pregnancy rates, this is the Canadian Canadian data uh, for all comers who did IVF in Canada between 2014 to 2022. This is the cumulative live birth rate per batch of eggs retrieved from a general population. And you can see that depending on the age of the oocyte, the egg age, there is different probability of live birth from each IVF cycle. So I think it's important consideration as someone is thinking about fertility treatment with IVF. Um, the last option, I would say that this is probably one of the least popular option that I see, but it is an option. But this is called laparoscopic ovarian drilling. It is a less common procedure, even though it is quite successful. It has similar pregnancy rate to FSH injections, but it requires a abdominal surgery. It's a laparoscopic surgery, so some keyholes in the abdominal wall, but it is a larger, more invasive type of surgery, even compared to IVF surgery. Where some puncture wounds are then placed into the ovary in order to remove the male hormone producing cells, or remove, or I guess decrease the amount of male hormone producing cells. And but there is a risk of scar tissue and excessive burning. You can lose some like good quality eggs from this procedure as well, just because the eggs cells are usually on the surface of the ovary. And then from a wait time perspective, there's quite a long wait time for surgery, and not very many providers do the surgery at this point. So there is some access considerations in BC. Um, those are all the range of different fertility treatments that we would consider specifically to this condition. Of course, becoming pregnant is a very important consideration, but we do have to talk about what happens after? What are the risks to pregnancy? We do know that in the literature, there's higher association with gestational weight gain, miscarriages, gestational diabetes, hypertension in pregnancy, preeclampsia, small for gestation and age babies, preterm delivery, and cesarean section. And it's important to focus on the lifestyle intervention that I mentioned earlier. It's important to access prenatal care, monitor blood pressure, and have early and proactive glucose screening in pregnancy in patients with PMOS. So I think I'm just kind of at the edge of the allotted time. So this is great. In summary, PMOS is a complex disorder, is a common cause of infertility, and there are several highly effective treatment that we can utilize to help couples conceive. But I think it's really important that even if you're here today with a diagnosis or without a diagnosis, that you work with your provider, because some of these treatments it may require more professional assistance, and it's something that we can certainly help with, especially for physicians in BC. Obviously, I can't speak to the resources elsewhere. Um, I think we just have enough time for a little bit of questions. I don't see anything in the chat box, which is great, which means my preventative, my kind of common question slides must have caught some of the questions. Um, are there any additional questions that you have for me before we end the presentation today?
Thank you so much, Dr. Cho. Thank you
You're so
for
welcome.
getting over time and for your amazing presentation. It was so informative. Thank you so, so much for spending this time with us.
You're very welcome.
And
My
I
pleasure.
hope that I'll see you next year for another one. It's,
I
it,
think
it
I
has to be a
think I
tradition.
think you'll have to you'll have to extend the invitation. I would love to join again. Thank you again
I
for involving
will.
me. It's my pleasure, and it's really great to meet you all. Best of luck in your fertility or just health and knowledge journey. And I hope that I'll see you guys again soon.
Thank you so much.
You're
Next,
so
Your
welcome.
Fertility Guide webinar will be on September 10 with Stephanie Curran, and it's going to be While You're Waiting, Mindfulness Tools for Stress and Uncertainty, which is very useful in a fertility journey. Thank you again to EMD Sarono for supporting this series, and thank you, Dr. Cho, for tonight. I'll see you soon. Bye,
See
everyone.
you
Have a
guys
good
soon.
night.
Bye.
Bye-bye.